You're listening to We All Wear It Differently, a podcast for early career psychologists. Your window into the world of the psychology profession. And now your host, Amy Fellman.
Hi everyone, welcome to episode 62 of We All Wear It Differently, brought to you in collaboration with the Australian Psychological Society as part of Psychology Week 2020. This year's theme is pain, finding the way forward with psychology. And in today's episode, I chatted to Dr. Jacqui Stanford, a health psychologist who leads a team of psychologists in the delivery of psychological treatment and pain management services at Empower Rehab. She also consults on the WorkSafe clinical panel as a psychology and pain management advisor. For more on Jacqui, check out the show notes. Before we get into the interview, the APS has provided Wowid listeners with a 10% discount code for a 2-hour Introduction to Pain Management training module, developed through consultation with Australia's leading experts and researchers. So go to psychology.org.au/We All Wear It Differently and use the code WOWID to redeem your discount. And now for the interview. Let's see how we all wear it differently with Dr. Jacqui Stanford. Jacqui Stanford, welcome to We All Wear It Differently.
Thank you.
So let's just start by you telling me, when you first discovered psychology, what got you interested?
I first discovered it in high school when it became up as a subject. So when I was looking at my preferences for VCE, it came up as a subject and it was one of the sciences, and I'm not particularly into the biology, so I thought I'd give it a try and see what was involved. And then it went from there. Started in year 11, studied it in year 12, and then straight into uni and loved it.
See, that's amazing to me. I never did psychology at school. It wasn't until I was 26 that I started thinking about it. So what was it about for you back when you were, 16, that grabbed your interest and just kept then fueling the interest?
I've always been fascinated by people, and my mum comments now that she could see that it was a career that made sense back as a kid by the questions I'd ask people. I've always been curious. I find individuals fascinating. I love asking questions. I love seeing what people are able to achieve, changes, and I've always been like that. So it just seemed like a natural fit. So I was very lucky.
So lucky, so lucky. Oh, it's much smoother that way than going in the back door a bit later on.
Exactly.
So then you decided that health psychology was an area of interest for you. So why did you decide to specialise in health specifically?
Well, probably a similar thing. So I feel like my career has just evolved by doors that are there, open them, I step through it, I like it, I keep going. So I did my honours year and was looking at what I could do post-grad, and applied for different masters and doctorate programs. And I wasn't interested in the really psychiatric end of psychology. So the clinical psychology bit and the amount of placement that I'd need to do in that didn't appeal. But similarly in health psychology, I wasn't sure if I wanted to do the health promotion, because for me, what I'm interested is that middle space. And so speaking to my supervisor, who was one of my mentors quite significantly in shaping sort of my career, Marita McCabe, she commented that she thought health psychology would be a really good fit. I didn't fully understand exactly what it was and involved, read through the course and thought it sounded okay, but it just, again, fell into it, and it's been great.
So what did you discover? As in, you talked about the middle space. What did it end up being?
So to me, I think what I love about health psychology is the link between the mind and the body, looking at someone as a whole person. I feel like at either end, I found I didn't get to see that change. I love working with people who have the capacity, the readiness to make changes in their lives, not just manage things. I'm someone who is efficient. I'm very focused and driven. And so for me, being able to see pretty quick, significant changes in people's lives, something that really inspires me, and believing in people and having that opportunity. So health psychology or community-based psychology with people with depression, anxiety, I find both of those really allow that opportunity to be part of someone's change and some part of someone's future.
And then pain. So, because, you talked to me about kind of not really loving that really clinical end. And it just occurs to me as we're having this conversation, as if in any psychology, the mind and the body are not connected. It's just so interesting.
Yep.
It comes up early. But so I'm thinking with pain, obviously we know that there is so many intertwined mental health challenges. Often there's even, the comorbidities that come together, say trauma and pain. So how did you end up building a business and a career with this focus specifically on pain?
So when I graduated, I decided from health psychology, I wasn't particularly interested in working though with sick people, and wasn't particularly interested in working with older people either. But ironically, I fell into a job. The first job that I applied for and got was at Cedar Court Rehabilitation Hospital, which is now Epworth. Involved in seeing people with a range of health conditions, cardiac, respiratory, pain, of course, then a lot of ageing population as well, and discovered I loved it. So despite my beliefs of what I thought I'd like, that opportunity was great because I worked in so many different areas with so many different people and ended up involved in the pain management program there. And what I loved is just how interdisciplinary. You cannot do it on your own as a psychologist. You can't do it from a single discipline. The way you had to really work closely with your colleagues just added to the enjoyment and the shift that you could see. I worked there for a number of years, and then following kids, decided to part-time. I found hard to get the same job satisfaction in the hospital because when I was full-time, you could be involved in other projects and other opportunities. So when after kids, I decided to work part-time, I decided to set up my own business as a psychologist, sole trader, and thought, I'm good at pain. I've been working in pain for the last few years. I can tell GPs that I work in this area. But what I very quickly discovered is my outcomes were terrible as a single discipline. As a psychologist, trying to work in that space was really, really hard because I don't know what someone's physical capacity is. Are they safe to lift that box or not? Or should they be bending in this way? I don't have the skills. And so that's, I suppose, in a sense, the start of why then Empower Rehab formed was how do we make it interdisciplinary in the community? It doesn't have to be hospital-based because I'm really passionate as well about things being out of the hospital environment, more in that community, well-being, living life environment.
Awesome. So tell us about Empower Rehab.
So Empower Rehab has been going for about 10 years now, and there's sort of three main parts to it. So because I initially started off being a psychologist with my own practice, we still have a significant part of the business that is a psychology clinic. So we have 5 psychologists in the team at the moment. We work with depression, anxiety, trauma, as a lot of psychology clinics do. And partly I'm really passionate about maintaining that for the psychologists in the team so they're keeping their skills up and exposure to a range of presentations. About 60% of the business is a pain management program. So we have physiotherapists and obviously the psychologists. We have some pain doctors that work with us as well to really look at how do we assess someone comprehensively, looking at the biological, the psychological and social factors that are going on for someone with their pain, and then looking at how we can address each of those factors in order to help them achieve their goals. One of the things that we've done, so we run sort of a more intensive group-based program. Obviously with COVID, it's not group-based, it's online at the moment, virtual and a lot more individual. But that intensive program allows people who need that sort of real immersion, behavioural activation to get that. But we also then see a lot of people who, what we call the functioning but struggling. They might be working full-time, maintaining a lot of their life, but they've got pain that's stopping them play their sport, or that they can't function what they want, kicking the footy with the kids or do parts of their job. So they're overall doing okay, but not the way they want to do. So we might do a lot less intensive program to teach them the skills and understanding, give them a range of strategies so they can get back to whatever level of functioning they want to achieve.
Do those people typically seek out psychology?
No.
So how do they end up with you?
Yeah, it's really interesting. I think one of the problems is, if I step right back and go pain and psychology, broadly speaking, is generally people are referred to psychologists once they've got the adjustment disorder with depression and anxiety. Even GPs who know that I work in the pain area, a lot of referrals will still come through. Please see Mary, who has ongoing pain for her depression and anxiety, not realising that we can actually target the pain itself, that we can actually address that before there are significant psychological problems. There's a lot of research that shows early intervention before someone's depression and anxious can just change their pathway. And similarly with that functioning but struggling cohort. So it might be through some physio clinics that we work with in the community will know that we work in this area, so we'll refer someone. It can be word of mouth, that people will go, oh, I understand that you work in this area, but still it's a very small cohort if we actually see at that higher level, and one of the areas that I'm passionate to see increase.
So for that mum or dad who's struggling to kick the footy because they've, injured their hammy, what's the treatment for them from a psychological perspective?
To me, you can never separate the treatment from a psychological perspective. So it's bringing the bits together. So the physio might be, say, looking at some exercises that they need to do to move them in that direction. What I'd be then doing supporting that is if that's a feared activity, we know that the way the body responds it'll inhibit some of the muscles. It creates a whole lot of stress, which we talk about as petrol in the pain system. So their thoughts might be, I should be able to do this. Why isn't this easier? Why can't I be a parent the way I want to be? I'm useless. I'm hopeless. So it's reframing that thinking. It's bringing in relaxation strategies. When I started working in pain 20 years ago, we'd run our relaxation classes for the clients at the hospital. The lights were out. We had Tony O'Connor rainforest music playing, and we'd teach people relaxation, and they'd fall asleep and snore. So I'd have to go around and poke them. And then later I went, that is so useless. Great for a sleep management strategy, but not when you're out at the oval trying to kick the footy. So we do a lot of functional relaxation of in movement. How do you do breathing? How do you get rid of non-functional tension? So how do you relax your shoulders while you're standing? We don't need them up here, up around our ears to be able to kick a ball. So bringing it into the movement, because in a psychology room, they might be very good at relaxing. As soon as they get the footy in their hand, that response can kick back in. So integrating thought reframing, relaxation strategies. Sometimes it can involve, say, looking at the emotional response, how to process, acknowledge the grief, the disappointment, the frustration, so that that's not bottling up and stopping them moving forward.
And what you said before really helped me understand was when you talked about the fear of kicking the footy. Is that kind of where it starts? That's that fear of what if I make this worse, and then is it just a kind of cascading of events from the fear?
Yep, because often then you have that fear, and it's a true fear. It hurts.
Yeah.
Pain isn't pleasant, so it's not an irrational fear. And I think sometimes we're at risk as health professionals to go, oh, don't worry, don't be scared of it. And it's like, hang on, I don't like pain. And our brain is really smart. If it's hurt the last 4 or 5 times that I've kicked the football, of course I'm going to be cautious, scared, worried, concerned about kicking the football again. And so what happens is people often avoid the activity. They stop kicking the footy, and then they get to the point of, oh, I'm fed up, I've just got to go out and do it. They'll go do it for half an hour, way beyond what their physical tolerance is, flare up, reinforce to the brain, see, kicking the footy leads to pain, can't do it, I'm hopeless, I'm useless, and they end up in this spiral of what we call sort of the boom bust. They'll push through and flare up, and then they crash and they give up. Then they'll push through. Every client I find has some degree where they'll push through with some things and they'll avoid other things, which is a normal human response.
Mm-hmm. Can that just be about what you like as well?
In what way?
In terms of what you push through and what you
Definitely.
You do more of?
Definitely. So one of the key things in a sort of thought-free framing way is I talk about choices instead of have-tos. But choices come with 2 sides to the consequences. So if I choose to stay out late because I'm catching up with friends, I'm having fun, it means I'm choosing to be tired. But we often don't think about that, I'm going to choose to be tired. We think about I'm choosing to have fun. So clients will often say, I had a client one time, and my approach is pretty direct. It makes clients move along a lot quicker, and it works for a lot of clients, maybe not all. And I said to this client, so you chose a flare-up on the weekend? And she goes, no, I didn't.
Oh.
And I said, hang on a second. What's your standing capacity? And she goes, 10 minutes. And I said, how long did you stand for? 3 hours. What did
Okay.
you expect was going to happen? She goes, oh my goodness, I did. I was focused on not being awkward at the party. I was focused on engaging with people. Hadn't even realised that passively, accidentally, she'd chosen to flare up. And it was a significant turning point that she was able to realise, how do I balance the demands here around what I want to be able to do? I love the footy, or I love parties, or I love gardening. We often talk to our clients about this can be too much of a good thing.
Okay.
We know it with food. It can be too much of a good thing. Same with activities that can lead to pain.
And there's a sense of a lot of power in that word choose as well. It sounds like in some ways is there an encouragement of kind of taking back control, because we know if we've got
100%.
agency over what we do, we also then feel more positive, and better about it.
And even more importantly, absolutely. So that's when I work with clients on reframing have-tos, it's the I choose, and I use the analogy being in the driver's seat. And I love clients because they add to my analogy. So I'll say, at the moment the pain's in the driver's seat and you're in the back seat. And I had a client say, no, I'm in the boot. I then had a client that said, no, I'm holding onto the back bumper bar. I've then had clients say, I'm actually running behind my car. I'm not even in it, my life at the moment. And so then I'm constantly saying, where are you at the moment in your car? Where are you in your life? Are you in the driver's seat, or what is? Because sometimes at the early stages of treatment, clients will put me in the driver's seat. Well, you told me to, I need to. And I'm like, look, I'm happy to coach you. I'm happy to be in the passenger seat. I need you to be in the driver's seat. Don't do the homework for me. Doesn't impact my pain. I need you to do the homework for you. It's your life and your recovery, and everything I'm doing is always going, how do I empower them? One, like you say, it makes you feel better. But more importantly, it actually changes the pain system. So we know with the pain system, there are three, this is simplifying pain science incredibly, but
Please do that for us. That would be really helpful.
there are three main components that will influence what pain people experience. One is the activities they do. So if I went and ran a marathon today, I would be sore. I have done more than what my body is conditioned to do. But for someone with pain, sitting for 5 minutes might be more than what they can manage. And that turns on. So we've got the physical demands. We've then got what happens to our stress system, our cortisol. And so the analogy we use in our clinic is that's like the petrol that goes onto the fire. The stress, worries, concerns, frustrations, annoyances, that will increase the sensitivity of the pain system and the messages that get through to the brain that increase the pain we feel. The third component is the endorphins, the feel good. The buckets of water is the analogy we use. That means that when you're in the driver's seat, that's a bucket of water. When you're in the boot, that's definitely a bucket of petrol. So by moving someone's thinking from have to I choose, I'm reducing their bucket of water by one, and we're adding reducing their bucket of petrol by one, and we're adding a bucket of water. If they're then choosing to only stand for 10 minutes at a time at the party, we're also managing that physical demand perspective. And unless you're looking at the physical demand, reduce petrol and increase water, people get stuck. So we need to always be looking at those three components in any activity.
Okay. I'm wondering, when you say to a client, you chose, the sensitivities that people with pain obviously come with, which is this sense of not feeling believed, supported, sometimes like a burden. Has it ever backfired? Is there a particular way that you do that to make sure that lands where you're wanting it to land?
Definitely you pick the right client and the right time. Not every client, not the first time you meet them. But I think sometimes though, because I speak to a lot of psychologists in my work safe role, but I speak to a lot of psychologists, and what I see sometimes is, as psychologists, we're obviously wanting people's well-being. That's why we do it. We want people to be better. We want people to feel better. But I think sometimes we get scared of upsetting them and their distress. So I think sometimes we're actually too gentle than what some people have capacity for. I would only go that direct once they understand the theory and the concept in lots of neutral concepts. So I choose to empty the bin so the house doesn't smell. I don't choose to empty my bin because I enjoy it. As they can start seeing the choice and consequences around a lot of non-emotive things, then it's easier. And it's got to be with someone who I've established that rapport, but I see rapport as an economy to spend. I build rapport so I can spend it. It's not about just building rapport. I need just enough to be able to give the intervention that can help them move forward.
Oh, I love that. I love that. That's such a good analogy and so helpful, I think, for psychologists to think about that. You know, personal experience, I left a psychologist years ago because I remember feeling like they never challenged me. And I felt I was putting on a bit of a show and I was like, come on, bring it on. I've come for the challenge. And it never happened. So I totally really understand exactly, you know, what you're saying and why that's so important.
I think we sometimes are, I think it's sometimes we're at risk of not validating the strengths of the clients that we have. They have life experience, they have a brain, they have emotions. Now, as I said, my approach is direct. My brain thinks fast. I want to move quick. So I flag with that with my clients first session. Hey, just so you know, I can see so much potential for you. I need to be careful that I don't push too hard, but I also don't want to go so slow that we don't move. So I can't read your mind. I need you to tell me if you're finding you're feeling overwhelmed or it's too much or too harsh. If you feel like something I say to you upsets you, offends you, I'd really love it if you could tell me that so we can talk through it. Because everything that I say and do is going to be doing what I can to help you in your recovery. Because I think it's really important that we empower the client to have that voice, not try and mind read and guess. One, it helps you not burn out as a psychologist. Means you don't have to try and guess where they're at. Just ask them. So I'll regularly say, if I get a sense that I might have been a bit direct, I'm like, what did you hear me say? Oh, you told me it's all my fault. Ooh, did I? What did I actually say? And so when you can actually talk through a client what they've heard versus what I've said, what I intended, and I'll straight out say sorry at times. Sorry, the word choice then was really clumsy. Did not mean that. I had that with a client last week. I used a particular word. She reacted to it. And I just said, that was a really poor word choice on my behalf. Can I please explain what I was meaning and then let me know your thoughts? Means I don't have to feel like I need to be perfect. It's much easier to say sorry sometimes.
And the power of repair as well, right?
Completely.
Relationship.
I think so much of what treatment is around those other factors, not just the content. It's teaching them that we can be hurt in a relationship and restore it. It's teaching them it's okay to say sorry. It's teaching them it's okay to speak up about thoughts and feelings. And so absolutely, I think so much around the structure of therapy is the therapy itself. How accountable we hold them to homework versus not, whether they're doing it for us or themselves, all of those things around the content is the therapy as well.
So we're talking about this end of the spectrum being, I guess, more minor pain, but or you know, and even in terms of kind of not being a huge mental health issue at the moment, more on the prevention, early intervention aspect. You said you're really passionate about that. How are you trying to drive more awareness in that space so you get more clients showing up with that presentation?
So I've been involved in the training that I do. So we run training for health professionals and return to work professionals, and we'll talk about it a lot there. I speak to GPs about it. I've been involved at conferences speaking about it. Wherever I can, being involved in different sort of webinars, just getting the word out there that it's possible. Yeah. What's really, I think it's going to take a long time to shift, and we know it takes a long time for science to move through to practice. I think the estimates used to be like 20-something years, and I find it 20-something years ago, we knew how pain worked, and I'd say there's a shift happening now. So I try to hold this balance of being passionate about it but patient. Sometimes the passion leads to frustration. Most of the time I'm aware that it's the long game. So I'm hoping just through repeated messages that we can gradually shift it. WorkSafe's great. They developed a policy a couple of years ago that allows people with a physical claim to access psychology for targeted sessions without it needing to be a mental health diagnosis. So they've now allowed, and that can be just addressing the barriers to their recovery. So it could be they've got poor sleep. We know that sleep is a problem. It could be communication issues with their employer. It could be that they're just feeling really overwhelmed by other things in their personal life, because we know a person is a whole person. And so it allows that targeted treatment. And the research that's come out of New South Wales shows that that significantly changes things. So WorkSafe Victoria has that policy there, which is, again, a step in the right direction.
Okay, so let's move to the sort of other spectrum. Who are the clients that typically present to you with more severe, debilitating, chronic presentations?
So we see a lot of people, if I just, my mind just think through my current caseload, I'll see a lot of people that have had significant pain, 2+ years, 5+ years, 10 years, where they're not working, they're struggling to function at home, they've had relationship breakdowns, they've got significant financial stress. Every single area of their life has been impacted. And so the great thing is with pain, it's the same strategies. It works. So I don't see clients for a long time. Most of my clients, we would see 10 to 15 sessions, and that can involve getting someone who's been off work for a couple of years, back at work, cooking, engaging with family, if you're addressing all the barriers for that person, which needs multidisciplinary or interdisciplinary treatment. And if you do that, they move quick because we're giving them the toolbox. Mm-hmm. So our results show that we get a significant improvement from our assessment through to our discharge. And then what we also then get is from the discharge to our 6-month follow-up, there's actually further improvement. So they have the skills and abilities, and that they continue to improve following that.
Is that 6-month follow-up structural in how you practice? Because obviously, psychologists that don't work in this space would love a 6-month follow-up with their clients, once they end therapy. So how do you bring that on?
So that's Empower Rehab is a network pain provider. Network pain is an initiative by WorkSafe and TAC that's really designed at trying to get people better access. But through that, we're part of a national database called EPOC. So it's the Outcomes in Persistent Pain, where we benchmarked across pain services across Australia. What they ask as part of that data collection is that a 1-ish month and 6 months-ish, the repeat measures of the outcome measures. So it initially started through that, but we've now brought it into our private clients. We look at going, okay, let's look at the time frame and explain why. We talk a lot about our role is as a coach, and then we're going to teach you the skills and train you, and we're actually going to get step back. But it's really important, we find, to have those reviews at that point to troubleshoot the little bits, because often by 6 months there might be a couple of little cracks or challenges that are there, and sometimes we can then pick up on that and keep them on track. Of course, they can contact us at another point as well, but it helps them with that accountability. And a lot of clients will say they like having it in the diary because it helps them make sure they keep using their strategies, which of course benefits themselves, but it allows them to have that relationship and know that, they're going to check in and let me see how I'm going.
Mm-hmm. Okay. So people injured at work or struggling at work because of an injury often have a really terrible time, and we hear this a lot. You obviously work in this space. Can you tell us about what sometimes happens for people in that predicament, and how you work with them?
Of course, every situation. Every situation is different. I think that in a way it's different because, of course, some people have high job dissatisfaction and conflict going on before they sustain a physical injury. Other people might love their job and feel really supported, and then they get a physical injury. So everyone's situation, even before the onset of pain, can be different. And then, of course, their response to the pain and the treatment and follow-up can be completely different as well.
Yeah.
So to me, any assessment needs to look at all the factors. So I said before, from a pain perspective, we need to look at the sort of the activity drivers, the petrol and the water. When we're doing an assessment, we talk about in psychology a lot, biopsychosocial. I think we can spit that word out so easily, but I don't think we actually look at what that is. And in particular, I think the social bit, we don't look at the social context anywhere near enough. And I still think in the pain area, I know in our clinic we're trying to do it more, but I think we've got a long way to go to do it optimally. Mm-hmm. Every single one of us lives in a system. We live in a family. We work in a workplace. And unless you understand all those factors, they will be the barriers that get in the way. So if I'm trying to help someone get back to work, they're increasing their physical capacity, they're managing their pain well, but I don't address the factor with them that they never were believed by their boss in the first place, that they had to go to conciliation to get their claim accepted, they've had their case manager changed 3 times, they keep getting reviews done as part of their work cover claim. If I don't address that stress, frustration, that's where they'll get stuck. So one of the analogies we often talk about in our clinic is it's like we've got a pie. Someone's circumstance is like a pie and there's different pieces of the pie. Exercises and lack of strength might be one part. Their thinking style might be another. Their tendency to push through might be another. Their workplace factors are going to be another. And if you get their thought reframing and relaxation 10 out of 10, but you miss the 30% of the picture that is workplace factors, they're not going to move forward. You need to be addressing each of the factors, whether it's you directly, or so for me, whether it's me directly as a psychologist speaking to the employer, which I'll definitely do, speaking to insurers, speaking to the OC rehab provider. Someone needs to address it. Whereas I think too often we can go, I'll stick to my little bit, you do your little bit, and there's a big bit in the middle that no one addresses. So with workplace, it's complex because our work is often our social, our financial, our meaning, our structure and routine. There's so many factors that go on in work for us. We know work is really good for us, but it can be tricky how we navigate that. So one of the key things we do is get everyone talking. I had a case conference the other week where we had 6 of us in the case conference because I'm like, this poor client had inconsistent messages throughout her treatment to date. And so I said, let's just get everyone in the same meeting. Then we all know what's been heard. It's all documented. It's all supported. And she just went, oh, I wish that happened 6 months ago. But she didn't even know she could have organised that.
Wow. How do you manage that being in a private practice? So obviously private practitioners are always struggling with the fact that they don't have the time to do all that interdisciplinary work that maybe they would like to do. Is it because you have so you were talking about, WorkSafe and some other bodies, I can't remember what you were calling them before, but you're involved with some government programs. Is that how you manage that at Empower?
No. We can do it with our privates as well. So a couple of clinical ways that we work that I think is really important is we work at sticking to the 50-minute hour. That allows 10 minutes to do your notes, your planning, make a phone call. We do a lot of phone calls in session with the client. It means we can model good communication. So I'll call a case manager with a client there. I can then have the conversation. We can then talk about it. So it's bringing it in because it's actually part of their treatment. I'll attend a case conference. That counts as a session, and I'll organise that with the insurer, and anyone can speak to them and say, hey, there's special codes they've now set up for case conferences when it's a return to work focus that allows that collaboration and communication. Because to me, I think often the trap that psychologists can fall into is we volunteer so much extra time, we research, we look up the homework, we find this resource, we do all of this, and then we get frustrated and burnt out. Whereas if it's actually, one, empowering the client to do the bits they can do themselves, so that we don't accidentally take that from them. So if it's researching, I get them to research first, see where they get to, and then I help them problem solve how to take it further if they get stuck. Bringing more of it into the session, sticking to your session times so that you're not chasing your tail throughout the day, making sure you're realistic in how many clients you can see a day. I speak to some psychologists in clinics where they're seeing 9 clients a day. I could not do it. No. We have for new grads, we talk about 5 clients a day in a 7.5 hour day. That's 2.5 hours. 50% of the time is allowed for the extra supports and all the extra little bits. As you get more experience, that goes up to 5.5, still allowing time for team meetings, but always looking at getting them to leave on time because we don't want them burning out, and bringing things into their session and getting more efficient rather than perfection.
Yeah, that is a hard lesson, we know, for psychologists.
Yes.
Particularly early on.
I think absolutely. I think the whole training program pushes the personalities and intelligence of people who go into psychology. Then the whole training program reinforces that. And obviously we really want to maintain a really high standard, but it's also important to go a really high standard for who? It's for the client. It's making sure that they're getting the high standard, not to our detriment either. It can't be at our cost. It has to be sustainable. It's also being aware of what GPs want. I speak to some psychologists who write GP letters and it takes them half an hour to write it. I ask GPs, they say, please, no more than a single page. Please don't go over the other page. I don't want to read it. If there's something really significant, give me a quick call and let's have a 5-minute chat. So things like that. It's working out what the audience wants, not necessarily writing a really comprehensive letter that captures every single nuance of what you're doing treatment-wise. In the same way, if a GP refers to me, I don't want to know every blood test, every differential diagnosis, everything they've excluded. I just want a letter saying, no medical cause for these symptoms. Please assess and address the depression and anxiety. Great. I'm trusting they've done all of that bit. I won't even understand it anyway. In the same way that a lot of stakeholders, GPs, other people won't understand our psychobabble. So let's not use it.
You've talked a lot about the loss for people with pain in terms of it might be being able to play with their kids, or it might mean not being able to work, which, feeds us so much. Tell me about the role of grief with people experiencing significant pain.
This is an area I'm really passionate about it because it can make such a difference in their response. In our society, we associate grief with bereavement. Even in that, we have so many rules and expectations of what it should look like, how long we're allowed to, how we should function. Even with bereavement, when we talk about chronic health conditions and the grief attached with that, it's a lot more complicated. And I love the term disenfranchised grief, the grief that is not acknowledged or validated by society and often by ourselves. So we, probably every single one of our clients with pain, we give them education about grief. We talk about we use a circles of grief analogy where if you're the person, you're the big circle, you lose something, either a death or a dream or your work. It's like there's a hole. In our society, we often talk about grief getting easier with time. Time heals all wounds. People say, is it getting easier? The problem is what that actually implies is the significance of that loss should get smaller, which if something matters to us, internally we're going to fight against it. So we talk a lot about the grief hole might stay the same size. What we want to do is expand you around it so you are bigger, you'll bump into it less often, but sometimes when you bump into it, it will still be just as painful as it was at the time. So with bereavement, that works because we can't bring someone back. When you're talking a chronic health condition, there might be multiple losses, part of their identity, their work, their dream of travel, their financial future. So it's like there's lots of holes, there's lots of grief that they're sitting with. The good thing is with pain, sometimes we can shrink some of those holes by getting them back, being able to kick the footy, getting them back to work. You can actually make it smaller, but it still won't be the same. It doesn't delete that loss, even if it doesn't delete that 2 years or 5 years that was significantly impacted. So we talk about the actual holes, the loss needs emotional grief strategies. So that's the crying, honouring it, respecting it, remembering things, allowing that emotional processing. The expanding ourselves is the practical grief strategies. And it's really important. We brainstorm with our clients what they would do with bereavement on both of those things, to get their brain open to the idea first and then get them to consider how they can apply that to their pain. Interestingly, it's so important not to judge or make assumptions about what's right. I've had clients that have chosen to light a candle in acknowledgement of their pain because they've done that with other family members. Now, that came from them, and that was a big turning point to their grief and allowed them to move forward. So if I then said to every client, you need to light a candle for your pain, that's not going to work because it's not the way other people respond to grief. They need to find their own way of what helps them process the emotions, acknowledge the grief. Firstly, to themselves is normally the most important, rather than necessarily even being able to get all family and friends agreeing with them. It's so much about that internal personal response.
I love that. That symbol of lighting that candle is such a symbol of peace too, isn't it?
Yeah.
If only we could set that for homework for everybody.
Without them then laughing or mocking, why am I lighting a candle for my pain? Didn't you tell me fire's bad and then petrol's bad and water? So we're going to get stuck in the analogy of how we talk about with pain.
Yeah, no, bad idea. So we're talking about grief. I know what's your perspective on stigma in terms of in society, in terms of people experiencing pain? Is there a lot of stigma still around, and do you see that as being a barrier for people getting treatment, but also that self-stigma?
I think there's stigma. I generally wouldn't use that word because to me it feels like an umbrella term. I think there's a really poor understanding, and through poor understanding comes judgment. There's ignorance. Yes. And so one of the things that I notice with a lot of clients is, so a lot of people with chronic pain will look well, especially if they're still grooming themselves well, they look healthy. Pain is invisible. And they go, if only I had a cast or a crutch so people could see it. Ironically, of course, the clients who I have in a wheelchair, the clients I have with the cast go, I wish I didn't have this so people would treat me like I'm normal. So there's pros and cons both sides. Often what I find is I'll say to them, well, how do you want people to respond to you? And they're like, well, I don't know. I'm like, well, this is the challenge. If you don't know how you want them to respond, how are they going to be able to do it well? Because often we need a bit of both. We need sometimes people in pain want some extra support and allowances, but they don't want to be babied or treated like idiots. And so it's looking at how do we actually find out what they want. So I talk to clients about no one will ever understand your pain. I can't feel it. Even if you gave it to me, even if you could give it to me for 5 minutes, I still wouldn't understand it because I know it's only for 5 minutes. The fact that you've got that pain day in, day out, can't imagine it.
How does that land for people? Because I know that's a desire. They just sometimes want someone to understand.
I think they feel sometimes relieved to stop trying to get people to understand, and then it'll be acceptance work about that's the reality. So then I'll be focusing on the acceptance of the fact that no one will understand it, which comes back to some of the grief and the isolation and loneliness that people can feel in it. So I talk a lot about self-compassion and being your own friend. Can you understand it? Can you nurture it? Can you validate it for yourself? Because often they're not doing it very well for themselves. They're judging it. Because pain is complex, people go, but I was at the movies and I had no pain. Does that mean it's all in my head? So they have their own questions around why their pain follows patterns. So they're not even validating themselves. When they understand, it's because you're releasing 50 buckets of water because you loved the movie, you're so engaged. Of course that changes what happens to pain. Then they realise they're not making it up. So it's really getting them to understand how pain works. When I said before, I think we could do a lot more at Empower around social. We're trying to get key support people, family members, partners involved more in the education and understanding so that they've got that support and engagement there, because that can be some of the challenges as a partner. If all of a sudden one day you can cook dinner fine and the next day you're saying you can't get out of bed, it's so easy to have frustrations and judgments. Whereas if people can start understanding the complexities of how pain works and lose that ignorance, then I think the judgments reduce.
How's that going for you, getting more of the, the support system to attend and participate?
Variable. Room for improvement. One of the things our physios
Scale
do.
of 1 to 10. Where is it currently sitting?
5. I have high expectations. I think
What about your enthusiasm levels?
Exactly. They're high.
10.
They're always high. I think part of the challenge is by the time a lot of people get to us, there's a whole lot of frustration with partners and family members. They're sick of it and don't want to be, or the client doesn't want to be a burden and take them out of their work more to be able to do it. And this is the problem when you're a long way down the pathway in people's treatment. There's a lot of experiences that have been there. When you do it, though, it can work quite well. That's why I say 5. We've done it a few times. Our physios, when they explain how pain works to clients, their homework is to go home and explain pain to a partner and come back with questions that they have and their partner or key family member has. So it starts getting that engagement at that point and gives us some really good information. So sometimes the client will come back and said, look, my partner now thinks that, everything's because I'm stressed, and they just keep saying, is it petrol? Is it petrol? And so that will be a flag. Great, this is a partner we need to really bring into the treatment because there's a lot of dynamics that we can hear there. Other times they'll come back and it just sounds that was enough engagement with them. They're able to take on board the strategies via the client and we don't need to. So it's really important. Otherwise we don't know what we're not seeing that will be impacting someone.
Yeah, that's great. I wanted to ask you about the role of trauma and complex trauma in people with pain. Do you see that a lot in your clinic?
Yes.
And why are they so intertwined? Why do they so often present together?
I don't know exactly, and the research to me is still really slow in terms of the interaction of pain and trauma. We know it. The people who have a trauma in their background are more likely to have pain. But we also know there's people with trauma in their background who don't develop pain, and there's people who develop pain who don't have trauma in their background. I remember being at the Australian Pain Conference a couple of years ago, and then over in Boston at the International Pain Conference, and speaking to some researchers from Sweden and Denmark who were looking at this area of going, and it was just nice to have it in a non-veteran area. So we hear there's the research in the veterans, but not in sort of community samples. It's starting, but it's slow. My hunch is that when you've got trauma, your nervous system, your stress system is heightened, which we know influences how pain happens. The challenge, I think, is importantly how we treat it. That for sometimes I think we can get bogged down in the trauma and trying to solve it. To me, most people with trauma in their background can do really well from pain management without even going into the trauma at all. Because what I'm always looking for is what are the perpetuating factors. So it might be they've got hyperarousal. So let's teach them to lower their arousal. They might have really high mistrust issues. So let's work really hard at addressing their trust. So sometimes you can address the current part of it without going back into the trauma that can actually start shifting that pattern. And through the pain management approach, by engaging in function and developing skills and strategies in that, they're able to get their life back on track, which is really good sort of supportive treatment for trauma, of feeling some sense of control, empowerment, which is often with trauma they've lost. So we have some people, if they've got PTSD or trauma that's impacting on their ability to engage in treatment, so they can't attend on time, they can't drive to the appointments, they end up so distressed at the smallest trigger that they can't engage, then we might do trauma treatment first and then move into pain management. If they're overall able to engage enough, we do the pain management first and then see if there's residual trauma that needs to be addressed. There's some interesting research around looking at movement-based trauma. And this is an area around whiplash that I think hasn't been addressed well enough yet, that physios might get clients with whiplash to do an exercise that involves moving their neck forward into a particular position. But if that movement was part of the trauma, they can end up with a flare-up and trauma response every time they do that movement because it's triggering as well, which makes it, we need to bring the psychological treatment in with the physical treatment, otherwise they're not going to be able to progress with their physical. So we often say to our physios, if it's not making sense physically of what you'd expect most people should be able to progress, it tells us there's something else going on. And so let's not just keep doing the same thing hoping for a different outcome. Let's work out what that barrier is and address that movement. So it might be changing how the movement's done initially, or it might be bringing in psychological strategies to support that movement, can help them then progress.
Whiplash, I think it's so overlooked, isn't it? People think that it's just a minor little thing, but it can leave long-lasting real problems for people.
Absolutely. And that's where some of the areas around pain and trauma are coming out of that area, and looking at which people are more likely to have the chronic pain, that persistent pain that goes on following the injury. Because some people do recover really quickly. A couple of days later, they're fine. But others, it's a very complex recovery pathway.
So what do people typically present with in terms of pain when they come to your clinic? So just for those of us that don't work in the space, so what kinds of pain are we talking about?
So the most common ones will be your back pain, neck pain, which can then lead to, say, shoulder pain. But because we're a pain clinic and we've been working in this area a long time, we get lots of different pain. So we see people with pelvic pain that might be related to endometriosis or bladder conditions. I've seen people with eye pain, nose pain, rectal pain, finger pain, like literally where someone might have had the tip of their finger injured. And so some people will look at that and go, oh, it's just their finger. Surely then they should be able to function well. But sometimes those people are so debilitated by it because, of course, when we have pain in our finger, our whole experience is pain, so it can still be hard. So we see pain associated with sort of physical injuries, with cancer, with Parkinson's, with other health conditions as well, because sometimes in those other medical conditions, it's almost assumed that, well, of course, just put up with the pain. So we know in cancer, there's a lot, we're really behind where we need to be, where people almost assume I shouldn't tell the doctor I've got pain, I should just accept it as part of my diagnosis, where the pain system is adaptable. We can't change the cancer, but we can change how someone responds and the pain they experience.
I just was thinking, you must have to be so knowledgeable, in terms of the health. I mean, you're a health psychologist, but, all the different intricacies that you're talking about in terms of how pain can present, and you've only listed off a tiny amount of probably the many thousands that could come into your room. Thank goodness for the multidisciplinary team around you.
Definitely you need the multidisciplinary team, because I would never have been a good doctor because my ability to store medical terminology is really poor. My ability to remember those details is not great. But this is where the other thing that we talk a lot about in a clinic is pain is pain.
Yeah,
Whether it is pain from a headache, whether it's pain from a back injury, pain from cancer, we have one pain system. So I also try and not get caught up into the actual medical diagnosis, because we know there could always be some biological medical component that we're not going to be able to address as a psychologist. Whether that's 5% or 50% or 80%, I can still be working on the 95, the 50, the 20%, and that can still change someone's journey.
Mm-hmm.
And it takes a lot of pressure off trying to...
Sorry, can you hear that?
Yes.
This is embarrassing. This is actually my husband's business is online, and he's got this Facebook thing that basically flicks over when he gets likes, and that's all I'm going to say. So that's what that was, would you believe? He's getting likes or dislikes. It makes that noise when you get dislikes too. You can see it kind of in the background there. That oh my God,
that's great.
It's not Siri today; it's the Facebook likes machine. Oh goodness me. You talk a lot about relaxation. We know that that's often central to the interventions. Is it mindfulness-based stress reduction specifically, or do you use MBSR?
This is where I did my training 20-something years ago, where all the mindfulness, all these terms come along, not specifically using it as that schedule. It's anything that decreases people's arousal. So to me, I think we can just overcomplicate and make it into these prescriptive ways of doing it. Basically, the thing I find the simplest is slow your breathing down, because you carry your breath everywhere. I have so many clients say to me, I can't do relaxation or meditation or mindfulness. I've done it before with a previous psychologist. I'm like, okay, so can you just do 5 slower breaths? They do it. I'm like, you've done it. That's all there is to it. Let's not overcomplicate it, because I think otherwise they have this so many expectations of rules of what it should feel like. I should be Zen-like. And of course, depending on what you are, what the physical or mental demands of what you're doing is, it's going to feel different. So relaxation laying down feels different while relaxation walking. So we can't focus on what the sensation is. So there's good evidence around a lot of those strategies. I don't specifically go, that's what I'm going to do. Clients in our intensive program will do some muscle relaxation, either your progressive muscle or your autogenic, but it's really developing a little toolkit for that person that works for them.
Mm-hmm. Love that. Oh, we could talk for hours. I'm gonna move on. Is there anything else you think I need to know about working clinically in the room with people with pain? Just anything that I've missed?
I think the main thing, when you go back to your stigma thing, I think the thing that's really important is if a client keeps telling you, I'm in pain, I used to be, if they're repeating themselves, something is not being heard. And until you've got that place of, even if it is, like I said before, being able to say to them, I'll never fully understand your pain, but I hear that that's really hard for you. Unless you get to that point, it's really hard to move forward. Definitely needs the multidisciplinary, interdisciplinary team, and that needs to be phone calls, not letters to GPs. You need collaboration, not just passing on of information.
Yeah, thanks. That's great advice. If a psychologist, a therapist is listening to this and thinking they'd like to learn more or get into this area, what would your advice be to them?
So there's different training out there that you can do to get a bit more of a taste of the content. So there's courses like Explain Pain, which looks at the real current neuroscience and has a lot of the good theory and science behind it. my understanding is a lot more of the science and that information rather than practical strategies. We run our 2-day workshop that is really practical. And so a lot of people who participate now have done both, and they say the feedback we get is they're both very different, complementary in that way.
Okay.
But I know there's lots of different courses out there at times around this area. So getting some education. I think the closer you can then work and talk to other people. So a lot of the learning I get is from physios, from pain specialists now, and then I just look at how I bring my psychology knowledge that we all have as psychologists to that space, looking at what those barriers are. So we can, and again, that has to be done through communication. When we employ people, we will look if someone's already got some pain experience, can be great, but we also look for people's stability to help people with behaviour change, people's motivational interviewing strategies, any of that. So enhancing any of your skills in those other areas, because that's so much of what we're doing is we're empowering people to get into the driver's seat. So any strategy skills you've got in that area, you can then plug the pain knowledge into that reasonably well. If you've got that ability to look at how do we help people function better with anxiety, grade exposure is not that different to pain.
I think that's really helpful, because I think often psychologists, early career psychologists, think they need to be an expert in all areas, to be able to work in them. But what you're saying is the fundamentals, we all have that. And it might be, seeking support from other people, brushing up on terms, that sort of thing. A 2-day course, absolutely we need to train, but it doesn't necessarily mean we need to go back and do a 1-year diploma.
Completely. Absolutely. And I think this is the thing that I see with a lot of new grads. So we've employed a lot of new grads over the years, and there's nearly every single one of them, probably about 6 months in, I'm like, stop. Let's focus on plateauing and consolidating your skill base. You don't need to read a journal article on the weekend and research every single condition before you see a client. You know a lot of stuff. Draw out, look at how you can apply what you know, because otherwise I think the risk is you burn out before you even progress in your career, and you constantly got this feeling of, do I know enough? I still don't know it a lot. So there's so much I'd like to know more, and I'll continue. I think it's having that openness to learning through your whole career. It doesn't all have to happen in the first year or two. It can't happen as well in the first year or two, or 5 or 10, 20. I'm up to 20 and I'm still learning new things all the time. And I really hope that I continue, because I don't want to be doing it the way I'm doing it now in 5 years. I want it to evolve. I want it to be better than it is now.
Love that. What are the biggest challenges working in this space? What have they been for you?
I think getting that recognition of psychology in pain without it being around mental health. I think there are challenges around funding and understanding, and that's shifting slowly, but it's a challenge to get people the amount of treatment they need. I think finding ways to collaborate is challenging. And when people have had a whole lot of frustration and failed treatment prior, to help them engage and let go of some of their hurt and frustration from past treatment, to be open again to moving forward. Because when we look at the mistrust and some of the trauma that happens and the injustices, it's often around other health professionals.
Yeah.
And so it's then being aware of that and going, how do I establish that trust with you when you've been promised everything from people before? How do I activate that enough hope in you to help you move forward?
So it might be the flip side of that, but then what are the biggest rewards? And perhaps do you have a little example for us of someone you've worked with that might sort of represent the rewards for you?
Oh, there's always rewards. I love it. So I think actually one of the traps with pain management that I see a lot is people keep going with a program without significant progress. What that does is it burns out therapists and it adds failure to the client if it doesn't work. We will sometimes stop people's program if we feel like now's not the right time for them to be able to get the most out of it, because I don't want them to feel like pain management doesn't work. Pain management works. The science is really clear. It just means that they're often not doing it. So we'll have conversations of, we're giving you the strategies, but at the moment, for some reason, you're finding it hard to implement. So we'll sometimes stop programs. The rewards are seeing people get in the driver's seat of their life, seeing them get back to functioning in all domains. So when we set goals, we always set goals around personal and domestic, their social and leisure, and their work. We need to look at them as a whole person. We find that when we've tried at times only doing 2 domains, they get stuck. It's only when you look at them as a whole person can they move forward, because for all of us, they feed into each other when we're healthy and well. So why would it not be for the same as someone in their rehabilitation? So I had a client, so many clients come to mind so a client that comes to mind is she'd injured herself at work. She was doing reduced hours, lower level duties. She used to be really active, hiking, cycling. She got hit by a car on her bike, so she'd taken up things like knitting and craft as her leisure activities, but she didn't like. She's a hiker, cyclist and everything like that. All her treaters had tried to get her to accept these other activities and try and get pleasure out of them. Mm-hmm. I like running. So if someone said to me, don't worry, you can't run anymore, start knitting, that is not going to make me feel very good, which is sometimes what we do. So we saw her in the intensive program, and she got back to hiking 5 hours, cycling, full hours, full duties with work within about 12 weeks. So seeing that change of when you address the barriers of how quickly, she can get to the 5 hours hiking in the 12 weeks. She was up to an hour, and then when we did her follow-up, she'd got to the 5 hours. But she took on the strategies, was able to apply them, use them in all different areas. But part of that was that she'd been hit by a car, like doored by a car. I actually went out on my bike with her to do the work. And I think one of the things as psychologists is we get stuck in our little white room rather than going, we'd given her homework, but she wasn't progressing. So we went out on the bike and she moved forward so much more quickly that way. So that's probably something that, again, I want to see Empower Rehab do even more, is just getting out there and doing it experiential. We do it a bit, but I think we can keep improving it, integrating, because then I was able to help her integrate the strategies to then make that progress.
Love that vision of you riding on your bike, moving forwards together. It's brilliant. Jacqui, if you had your time again, what would you have liked to have known earlier in your career?
I think I was actually really lucky. I think I had amazing mentors and supports through my career. So there's nothing in particular that I wish I had known. What I did know and what I was told well is it's not my responsibility to fix clients. It's not on me. My job is to bring what I can to the table and do what I can to help the client pick it up and do it, but it's not all on me. I think one of the traps is as psychologists is we can feel responsible for our clients more so than is helpful, and I think that's at risk of burnout. I think trying to go above and beyond and getting caught in those patterns can be really hard. It's accepting you'll never know it all, so work with what you've got and do that bit well is probably some of the things that I think, and make sure you look after yourself. Look after your own mental health, well-being, your time management, how many hours you work, what the role is. If a job doesn't suit you, find something that does. Psychology is a massive profession. There's so many areas we can move. Find what gets you excited. I would have never thought pain would get me excited, but 20 years later, I'm still incredibly passionate about it. And so I go, pursue that. And that comes by taking time and working hard in it, but the rewards are there.
Okay, and taking opportunities when they present sometimes too, even if they don't fit the actual kind of book that you've written for yourself.
Definitely. And I never wrote a plan of what that was going to look. So, the fact that I just opened doors, go through them, like it, stay there, didn't like it, go back out, find something different. I think an analogy I use with clients is it's easy to steer a moving ship. So same in your profession, it's easy to work out which way you want to go by trying something and moving forward rather than sitting, waiting, thinking, contemplating, because you're not going to know what something is like until you're in there. I didn't want to work with old people or sick people. I now work in rehabilitation, and it's the most rewarding, amazing work, which I would have never pictured when I was 20 trying to work out which way I was going to go.
Incredible. So it's so inspiring. And, people think, I can't just do anything. I need a plan. You can plan to do anything. You can plan to try things out. That can be part of your plan.
And you can always learn something in that. There's learning. There's no such thing as failure or success in that. It's learning. What do I learn I like about it? What don't I like about it? Exploring and allowing time. I think sometimes there can be a sense of urgency of getting it sorted. I don't think we ever get it sorted.
2 years, 5 years, 7 years, 20 years.
Yep.
So my final question for you, what's exciting you about the future?
In the pain world, what excites me about it is the moving into the early intervention and the functioning but struggling. I just think there is so much scope. That's why we're waiting 2 years, 5 years down the track when someone's life has pretty much fallen apart, when we know that in 3 months, 4 weeks of an injury, we can predict who's likely to develop chronic pain and we can do something differently. So I'm excited by the potential there to actually change the course of people's lives with really minimal intervention earlier. Don't quite know how I'm going to get that on the profile enough of the world and change that, but I'm going to keep chipping away at it.
Oh, Jacqui Stanford, thank you so much for speaking with me today on We All Wear It Differently. It's been lots of fun, very insightful and inspiring. Thank you.
Thank you.
Thank you, Jacqui. An energising and insightful conversation. I hope you enjoyed the podcast as much as I did. For more information on Jacqui, check out the show notes. This episode of We All Wear It Differently was brought to you in collaboration with the Australian Psychological Society as part of Psychology Week 2020. For more information, head to psychweek.org.au.
You've been listening to We All Wear It Differently. Subscribe at weallwearitdifferently.com.